Hello, my name is Sarah Wack, and I'm a student at the University of Buffalo and a summer education intern with the Jacobs Institute. I'm excited to welcome you to the third session of the Jacobs Institute's high school webinar series. The Jacobs Institute is a medical innovation center located on the Buffalo Niagara Medical Campus and sponsors collaboration between clinicians, researchers, engineers, and entrepreneurs to develop medical devices. Over the course of 4 webinars, our host, Dr. Ken Snyder, will discuss the ever-changing world of medical practice with emphasis on how different interests can collide to create new innovations. Dr. Snyder is a dual-trained neurosurgeon and a part of the University of Buffalo's neurosurgery department. His additional training and specializations has helped given him the necessary tool set for specialization in the comprehensive management of neurovascular pathology in both the brain and spinal cord, including treatment of aneurysms and stroke. Also joining our session today is Dr. Thomas Hughes, who will offer his expertise on COVID-19. Dr. Hughes is the Chief Medical Officer of the Optimum Physician Alliance, a collection of 600 physicians across Western New York who work in concert with Kaleida Health to improve the quality of care in the region. Prior to that position, Dr. Hughes was a family physician in solo practice for about 20 years. The Jacobs Institute's high school representatives, Janat and Josh, are also joining today's webinar session. Janat is a rising junior at Public School 197, Math, Science, Technology Preparatory School, and Josh is a rising senior at St. Joseph's Collegiate Institute. Today's session will continue to illuminate the intricacies behind stroke and COVID-19 as Dr. Snyder and Dr. Hughes discusses the relationship between the two. At the conclusion of today's webinar, a link to a SurveyMonkey will appear, and if you miss the opportunity, the link will also be included in the automated email from Zoom that will be sent to participants tomorrow. Please complete the survey as the responses will continue to help us improve the webinar experience for attendees. Questions and comments are always encouraged. Please type any questions you may have in the chat box on Zoom during today's webinar. Questions will be raised when relevant during lecture or answered during the Q&A section scheduled in today's program. Please keep all questions and comments appropriate and respectful. There's also a voluntary discussion opportunity for those who wish to connect with other attendees outside the webinar series via Slack. With this platform, participants, if they choose, can continue the discussion with others and help foster a community of shared interests. Attendees will have the opportunity to opt into the Slack discussion by leaving their name and email in the post-webinar SurveyMonkey that will be available at the conclusion of today's webinar. As a friendly reminder, participants will have the opportunity for their names to be drawn to attend a smaller Zoom meeting with Dr. Snyder at a later date. All participants who have attended at least 3 of the 4 sessions at the conclusion of the series will be automatically entered into the drawing and if chosen will be contacted via email. Without further ado, I present our wonderful host, Dr. Ken Snyder, and our special guest, Dr. Thomas Hughes.
Sarah, thank you so much. I was mentioning to the panelists before we get started today, I'm tired. I've been on call. Just hearing Sarah's energy picks me up, and I'll be relying on the panelists and all of you taking an hour out of your time. I think any teacher, it can take a lot out of you, but getting enthusiasm from the students in the audience truly is energizing, and it's why we do what we do. So please send a bunch of questions, interrupt me. I'm really pleased that Dr. Tom Hughes, my friend and colleague, is willing to join us today. He has been instrumental in the community effort around COVID. Many of you in your responses to the surveys have asked questions like, how is COVID transforming healthcare? How is it making us better doctors? How is it making us communicate more? These are the very questions that Dr. Tom Hughes has driven the entire community to answer and has been the leader in how and why we've done this level of transformation. So what I planned on doing today was covering about 15 minutes of closing out stroke, and then rolling into COVID, since there's so many comments and questions on it, and then having that spill over into tomorrow, and that whatever time we have left covering some of the other topics. But I think covering COVID for the next 2 in the majority is really important based on all the questions that I've gotten from each of you. Tom, thank you again. Josh, Jeanette, that doesn't mean you both are off the hook. You guys better come chime in. I promised I would start each session with the video. And with this video, I want to show a special type of surgery in neurosurgery called endoscopy. What's unique about neurosurgery that I love is that we are trained anywhere that there are nerves. So not just brain and the entire spinal cord. I have surgical access and training in every one of the nerves that then leave the spinal cord and go anywhere throughout the body. So the beauty is you learn the anatomy everywhere. I do carpal tunnel. I'll do pelvic excisions for neuroperipheral nerve tumors. It really becomes an incredible breadth of field when you're a pediatrician doing this work, because then you don't even have the adult subspecialties. You truly do everything on that young child. It's an incredible breadth of surgical skill. Endoscopy is operating through a little tube, and they haven't come up with a way of making the tube see like our eyes. It's not binocular work. These are single lens operating. And so the way you get, what do you lose without two views? You lose depth perception. And so what's interesting in endoscopy is the way we develop depth perception is we shake the lens. By moving the lens back and forth, it gives us a little bit of depth perception. But technologically, we need to find a way to put two small tubes down at a little bit of an 8 angle so that we could truly depth like we do with our eyes. Realizing, again, separate conversation, there's a lot of illusion and a lot of three-dimensional things we lose by our simple two abilities to see, which is two perspectives. Separate conversation. Endoscopy. Everything up here, so here's the frontal lobe of the brain. This is a side view. Here's the midbrain and spinal cord and our bones of our spine. Here's the tongue. These are nasal mucosa. This is what's called the sphenoid sinus. It's a fancy way for saying an air pocket in the bones of your skull. Behind that is the pituitary gland. Right above the pituitary gland are optic nerves, which we saw in one of the videos before, going out to the eyeballs. What you have to be careful about, so one thing that's interesting is you can go through the nose and get right to the brain in the back. It's above where you swallow and bring things down your feeding tube, but right there is the pituitary gland. So if you could stick a tube in the nose and crack the base of the skull, you're in there. Okay. And so endoscopy, which has really been a field of neurosurgery and pituitary surgery work, which is one of the original fields because there's so many pituitary surgeries that have been done, has been an art that we've perfected. The thing you need to be careful about, going too deep. You go too deep into this structure, you've got a lot of high value real estate sitting here. So when we do pituitary surgery, we pick a nose, we come directly through, we crack a couple of the nasal bones, we break through some of the cartilage in the back of the nose, and then we've got a wide field of exposure. We drill here, being very careful, because guess what that structure is and that structure is. Remember I showed you the aneurysm surgery where there's a nerve to the eye, and you see the cross, and right next to it is the carotid artery. So you don't want to be drilling anywhere off axis, or you could be drilling down onto the carotid. So we use bony navigation to ensure we're exactly where we need to be. You see how there's this little spike right there, that little peak? I don't know if you notice it, again, right here. You'll see that in the video. That's one of the ways we know we're midline. We drill that down, open the covering of the brain, and there's between tumor and normal pituitary gland. So I want to show you what that endoscopic procedure looks like. So here we're going into the nasal mucosa with that with tools. We peel off some of the mucosa of the nose and break the cartilage to get to the back. Okay, we're at the back, and remember I told you there's that wedge of bone. That's that wedge of bone in the middle. We're drilling that down. Carotid artery is hidden behind the bone there, carotid artery on the other side, and we literally crack a shell into the back of that skull base, and that's the covering of the brain. That's the dura. We then take a knife. Now remember, we're looking at this all through a monocular lens. That's all we have is a little tube back there. We cut a component of the covering of the brain. The minute you open up the covering of the brain, you've got spinal fluid. And then you're literally looking at tumor or a component of brain tissue. This obviously was a very milky, frothy type of tumor. You're going to see under pressure, it literally delivers itself once you've opened enough of the dura. Boom. That's all the component of tumor that's become avascular. You send that all for specimen. The healthy pituitary, which gets pushed out of the way, is a very robust fibrous structure. It doesn't come out at you if you just grab it loosely without something sharp. We drill a little more of that structure to ensure we get as much of the tumor as we possibly can to decompress the optic nerves. These patients often present with vision difficulty. And then we take fat from someone's body, plug it into that hole to basically plug the leak at the bottom of the fishbowl so that fluid doesn't pour down into the nose. And so after we push fat up in there, we put a patch of covering over that acts as Nudura, and we basically glue it shut. But again, I wanted to show you guys videos of cases, different styles and different types of cases. I'll try and find a spinal nerve sheath tumor case for next time. All right, the theme for today and follow-up is pushing boundaries safely. No matter what disease process you study, you have to understand its natural history. I'm going to give an extreme example. Jump out of an airplane without a parachute. What's the natural history? Not good, okay? All right, everyone will die, depending on your height, when they hit the ground, okay? That likely is not the scenario you want to do a randomized clinical trial for, right? Randomized clinical trials mean you're not sure what's better. Should I jump out of the plane or should I jump out of the plane with the parachute? I don't know which one gives a better outcome. Of course we do, okay? But the nuance of that question of, well, what if someone's only 6 feet off the ground, right? Do they need a parachute? What can happen? Are there risks in tripping when they hit the ground because they've got a parachute on them? More important is, what's the natural history of what happens when you jump from 6 feet versus 6,000 feet, right? So sometimes people get so excited about the intervention that they forget about the right group to study it in, if that makes sense. Also, some people love trials so much that they think you need to do a randomized trial to prove anything. No, you just had 100 people drop from a plane, they're all dead. You don't need a trial to show that the parachute is going to save lives, right? It's a very important concept in anything that you go into around trialists. It's for equipoise only. Understand the natural history of what you're studying or what you're doing is the first most important question. A couple things from TED Talks that I hadn't sent to you guys, and I sent 2 links from them that are going to be important for the second half of the conversation. And these are kind of my questions of how I think about things in terms of relative aspect and importance. 50 to 100 million people died of the Spanish flu in our grandparents' lifetimes. This is within a generation or 2 of us. Let's put that number into perspective. That's more than both of the world wars of the entire world combined. Yet, how much have we ever talked about that compared to the history that we discuss around both world wars? Pre-vaccination, that was 1/10 of the population of the world gone from a virus. And this has happened throughout our history periodically as we've started to centralize, increase our population. And what's made things so risky recently is the amount of interconnectedness in air travel that we do and the amount of interconnectedness in supply chain globally that we have. Other really exciting and interesting conversations are, what the heck is a virus? Why and where did it even come from? There is more genetic variation in viruses than there are of every other living species on the planet put together. Viruses are parasites that infect plants, every other form of life form that there is, and they have the ability at some point, depending on the mutations, to cross species. There are multiple theories about what and why viruses developed or what they become, and they may or may not be related to things called mitochondria that are independent genetic entities that live within our mammalian cells. But we have, or they have, the ability to incorporate into our DNA or take snippets of our DNA and send it elsewhere. So there may have been needs or ideas of the ability, even amongst our species, to be able to have many different mutations depending on scenarios, that these viruses actually serve a purpose of sending this genetic code across multiple species for various reasons. All they are little bits of RNA or DNA. That's all they are. There's no protein. There's a little envelope. How can these little things of numbers accomplish all of these potential tasks or have that much impact on a species and cause death? Really interesting questions. It involves evolution, ontology, phylontology, biology, but there's a couple good YouTube clips on asking those questions. And in fact, there's an entire new field called paleovirology and genomics that are really just entering, asking these critically important questions. And hopefully we'll get to some of this when we cover COVID. I wanted to finish up in 5 minutes, let's say, on some stroke things. Stroke, CAT scan of the head, okay? You can have two different types of strokes. One's a hemorrhagic stroke, one is an ischemic stroke, okay? Hemorrhage means there's blood in the brain. On CAT scan, bleeding is bright. There's blood here, it's an epidural. There's blood here, it's a subdural. Blood here, it's in the parenchyma of the brain. Blood here, it's in the subarachnoid space. Blood here, it's in the ventricle. That's not what an ischemic stroke shows. CAT scans are great for seeing blood that's popped out of a blood vessel and is filling the head. Ischemic stroke, as we talked about, is a blockage of a blood vessel. There's no blood leaving the brain. There's lack of blood supply. And what happens is the brain starts to become edematous, and the features are very subtle. This caudate's a little bit darker than that one, which is a little bright. This cortical ribbon of gray and white matter is very sharp right here, and over here there isn't any. Those are the only subtle features that were picked up on previous imaging. And we already told you that MRI doesn't give us a good amount of telling us whether tissue's dead or alive. So we started to talk about the ability to do perfusion imaging and actually take 20 pictures of the head in 1 minute, where we look at not only the blood vessels light up with dye, but the actual capillaries in the parenchyma of the blood also light up over the flow of blood through the capillary bed. And as that happens, we form these tissue attenuation curves of the dye going into the capillaries and coming out. And remember, the blood volume is the area under this curve. And we talked about measuring that has transformed our ability to treat stroke and assess whether tissue is alive or dead. If we have sufficient and good blood volume, I don't care what's going on for time. It could be 2 days later. If the brain tissue shows me normal or good blood volume compared to the other side, it's viable tissue. If the blood volume drops to 1/3 of what it should be, it's probably dead tissue. And that's really some of the basics behind it. So again, how does this happen? Here's the carotid artery. Here's the middle cerebral artery. Here's a blockage. Here's the anterior cerebral artery. This brain tissue is ischemic. The brain's got 2 ways of getting blood there. The first thing it does is it takes the small capillary channels and it dilates them to as wide as they can go. Just like in the AVM, that makes this a sump. And what happens is rather than go to high resistance tissue, blood shunts to this area and pools into this area. That's how we keep that brain tissue alive. The second thing that happens is the brain tells the heart, pick up the blood pressure. I want high pressure because I need to drive blood to this region. Those 2 mechanisms are unique for every person and how well they work. But in each person, you could potentially sustain this blood tissue for days if needed. There are other people that don't have the collateral and the brain tissue dies off in a short period of time. Our key is this imaging telling me that the brain is viable and good is what lets me wake up at 2 o'clock in the morning, rush in and take this clot out to get that tissue back and healthy, okay? So here's a quick example in my conversation on natural history. We published over 10 years ago that we could use this imaging and take people with high stroke rates that would die otherwise and take them, and 30% of them went home. So there's a 90% mortality if you don't do anything. On the flip side, if the imaging looks good, 30% of the people went home. We made this argument for 10 years and said, you don't need a randomized trial. This is the parachute analogy. If you don't do an intervention, 90% are dead. I'm sending a third of them home with good imaging. What are we doing? Unfortunately, neurology as a field said we need the randomized trial to do this. So what happened? We took people that are less than 80 years old, say 40. They have good viable brain with very small cores. They have a high NIH stroke score. That's a death sentence. And we did what? We randomized them to no intervention or thrombectomy. 100 people needed to die in this trial before it was stopped short. And now all of a sudden, as American Heart, American Stroke guideline, we use imaging and do thrombectomy as the standard of care. And unfortunately, we had to repeat that in another trial. 2 randomized trials, both with 100 deaths, both with the same outcome, radical improvement in thrombectomy. We tried to make arguments of cohort medicine to do it. Look at, again, the differences in terms of independence. In one trial with thrombectomy, this is a score of independence compared to the other. You know, here especially, we're sending 40, 50 people home independently compared to 5 people in the control group. They never even went to the completion of the study. It was such a powerful finding. I come back to the analogy with the parachute, and unfortunately, we don't all understand or believe that equipoise is what we need to go for clinical trial. I have 3 quick cases I want to talk about, then we'll start COVID. This is a perfusion study. This is what those pictures look like. This is time. There's a huge time delay in this region of brain. This is viable blood flow and viable, if not better, blood volume. This is a perfectly healthy brain. This is someone who woke up with a stroke. Remember, pre those studies, there's no treatment option for this person because you don't know the time of onset of their stroke, so they can't get TPA'd. Here, we would say the viability of the brain's great. I don't care the time of the stroke. His stroke score is very severe. Take him to the angio suite. And that's where we do our glorified plumbing. This is the angiogram. Dye within the blood vessel, carotid artery coming up, it's blocked right there. There's supposed to be flow that goes out here. As I mentioned, you don't see it because there's a blockage filling the pipe, okay? We then go out with our wires and tubes. We blindly cross the clot, put a small tube there and do an injection. Hope that we see a blood vessel instead of a plume of smoke. If we saw a puff of smoke, we know we would have ruptured that blood vessel as we were going out there. Because remember, we're navigating blindly. We then drop a stent retriever, the stent that's a fishing net on a stick, and we pull out chunks of clot. This procedure only took 15, 20 minutes, and we immediately revascularized that tissue, and the person walked off the table basically right before our eyes, thanked us for what we did, and went home in 2 days independently. This happens enough of the time, right? This is 60%-ish of the time if we pick the right patients. These are great outcomes, but not everybody shows up with that kind of imaging. Severe stroke presentation, NH18, look at the difference on the scan. We have a delay in a territory, but now we've got no blood volume in 2 regions. There's a little island that looks good, but 2/3 of the territory that's at risk looks like it's already dead. And I normally would say there's nothing I can do. I'd never be able to help this person. This was the father of a neurologist who said, I don't believe any of the research you're doing. I said, listen, I'm going to go up past the clot with a small tube and I'll do an injection. What happens if the blood vessels have dilated too much and become too leaky is that it shunts, just like an AVM does. The dye will go right to the vein. If that's happening, the tissue is not healthy. And so this was an example where I went up across the clot, did an angiogram, and the arteries and the veins showed up at the same exact time, and we didn't do an intervention. Another issue is, what if only a small amount of brain tissue is dead in a large region that you can save? Those are people that you'd want to take every time, but it doesn't mean you're off the hook. Because in this scenario, I opened up the stent retriever to remove the clot, and you see this area here? Does that look like a small blood vessel? It's a puff of smoke. That's bleeding in the brain right before your eyes. And so here I am with the stent retriever open and I've got clot embedded within it. If I pull the clot out, patient's just going to keep bleeding and likely die. So I actually went up and recaptured the stent retriever, forcing clot to sit there, or else I would have glued the blood vessel shut. So I shut the vessel off again. That means the patient's not bleeding. What could I have done in this scenario? This case made me say, why did I have to stop here? Why couldn't I have gone back through with the small tube, find the blood vessel that's bleeding, and glue that one shut, and then come back and open up the big clot? This was the case that made me think of that. And in fact, now that's exactly what I do. And this is as cutting edge. That's the patient that bled on the table when that blood vessel was open. Now what I do is I have somebody that shows up with a basilar occlusion. This is the most important part of the brain and the brainstem, but they're bleeding into their brain. Rather than say there's nothing I can do, what I actually do is I go up. So here's the occlusion. The bleeding's occurring up here. This is the most important structure to open up to get blood back to the brainstem. I go out and I glue the distal blood vessel shut where the bleeding is. And then I come back and open up the blood vessel. Does that make sense? So we're actually using the physiologic imaging now to tailor how aggressive I could be on the stroke treatment. And that's as cutting edge and revolutionary as we could be. There's no guideline on that right now. That's the frontier of what we're pushing with stroke. Does that make sense? Any quick questions on stroke before we transition to COVID?
Yes, we have a question kind of regarding the dead tissue. So what kind of effect does the dead tissue have on the brain? Because we're trying to get it out, but what exactly is it causing?
So it depends on the region of brain that's infarcted. If it's the region of brain, so when we talk about the tissue and the focal regions of where they work, let's imagine out here on the cortex are the cells that control motor function on the other side of the body. So if this is the right side of the brain, the left arm wouldn't work. If this is the right leg area, the left leg wouldn't work. But it gets more tricky. Once you get away from the cortex, all there is the cabling going through the brain. And so if you get deep down into the brain where all the cables from these areas travel, you can have a stroke in this region, and that stroke will devastate the movement on the other side of the body. So it's all very dependent on where the blood vessels go to. They could go to vision centers, they could go to motor centers, they could go to complex thought centers. It just depends on where the pipe is leading to. Any other questions?
Nope, that was it.
Before we transition to COVID, then I'd like Dr. Tom Hughes to make a couple comments. Tom, there's been a ton of questions on what has COVID done really from us transformatively as healthcare providers, as a healthcare system. And there's also just a lot of questions on, I want to learn more than just neurosurgery. What's some advice for people that are interested in medicine? The kids that have taken the time for this call come from every facet of interest of math, chemistry, biology, but hopefully even English and other. And the idea is, how do we inspire and give advice to any that wants to go into any realm of field around healthcare?
Beautiful. First of all, I want to thank you for the presentation. I want to thank you for the series. It should be obvious to everyone on this call that Dr. Snyder is a rock star, and you're seeing stuff today that is fiction 2 years ago. So this is where healthcare is. But I actually want to go back slightly to a couple of things you talked about before I get around to answer your question. The first thing, I had to laugh when you talked about jumping out of the airplane. I don't know if you had an opportunity to see it, but there's a British medical journal, Lancet, which is this very prestigious established journal, and they actually published a randomized control study about the efficacy of parachutes and jumping out of a plane a year ago or 2 years ago. And basically what their conclusion was it made no difference whatsoever. But then when you went to go and look at the methodology, it turned out that they set the plane at 1 foot off the ground. And I think the point of publishing the article was to challenge our assumptions of data about what we know and what we don't know. And I think that your story about the procedures in neurosurgery and the process of going through it is critical. at the end of the day, the only true north we have is science. That we need to, science will evolve. What was true when I was in medical school is not necessarily true today. What is true today is not necessarily true tomorrow. But if we don't hold ourselves as a profession and frankly as a society to that North Star, then we're nowhere. That everyone has an opinion and everyone is entitled to their opinion. But the facts we generate and operating off of those facts is critical, not just in neurosurgery, not just in our response to COVID, but how we operate operate collectively as a community. Moving back to your question, I think one of the
let me add one other thing. A brilliant comment. I got to get that reference from you. But for the crew on this webinar, one mistake you can make is that just because it's been peer reviewed, you think it's right. I can't tell you how many papers I've seen that we thought were excellent written papers in medical journals peer reviewed that have been completely overturned by different lines of thinking. Scientific evidence is out there, but it's meant to be challenged. Challenge any of those papers, no matter what journal it comes from, until you know it deep in your bones. Thanks for those comments, Tom. I think they were critical.
Yeah, no, I absolutely, that there is no single source of truth. Truth is arrived at through conversation, communication, and your stroke stuff is a perfect example that everyone knew you couldn't do anything. That brain was dead and we were done. And I remember more than one conversation, with patients coming to the emergency room, and they woke up paralyzed on their left side, and it's like, well, shame you slept a full night. There's nothing we can do now, and that's what they were left with. And it was people like you and your team that challenged that presumption, and have not just redefined the field, but redefined these people's lives. So there's an old expression: you need to have strong beliefs loosely held, and I think that's where we are. That we take the best science, and we act on it in the present moment, but we constantly challenge it. So
the last piece, and then I'll have you continue on COVID, is the reason, again, Tom and I have such a strong relationship, or the reason there needs to be collegiality, we can take a success story of what we've been building, like I just said, and unfortunately, it's easy for me to take it to an extreme. I can say, oh, I've got a patient that's got a mild deficit. Let me put them through a risky procedure to see if I can make them perfect. And that's when the Tom Hugheses of the world say, Ken, wait a minute. That person's going to live fine. Their quality of life's going to be fine. Why are you going to put them through something riskier to try and get to what you're considering perfection? That's where the collegiality of medicine and picking the right people to study is so important. It's always a risk-benefit conversation. And that's why you need partners in these fields as you push these envelopes.
Yeah, I couldn't double more. For those who haven't figured it out yet, Dr. Snyder is infinitely smarter than I am. And it is important that medicine have people with that level of brilliance. I come from the opposite background. I came up through the liberal arts. I trained in internal medicine so that I don't cut anyone open. Fortunately, I'm not the one who's called in the middle of the night. But I think the result of that is a very interesting conversation. There's an old expression: if the only tool you have is a hammer, the whole world looks like a nail. And so we all come into conversations with our own agenda. That going back to the stroke issue again, that I'll look at that patient and say, there's nothing we can do. I get challenged by Dr. Snyder. Of course, there's something we can do, and it provides better care for the patient. Speaking as a primary care physician, I think we have sort of an interesting role in the conversation, that we are surrounded by subject matter experts. Dr. Snyder knows infinitely more about neurosurgery than I've ever aspired to know. And I could fill a room up with organ-specific specialists who know more than I know. And that's not really my charge in the discussion. My charge is to step back from that and look at the complete patient and figure out how the nervous system connects to the heart, connects to the lungs, and how that impacts the larger patient. And so I think when medicine practices at its best, you see synergy between those groups to have a real conversation, which is focused more on the patient than on our capacities.
It's a perfect transition for you with that view, and it's because of that view that you were able to ground all of us and give us focus around COVID. Speak to the experience from population health and then your focal point around telehealth, and even interacting with Erie County, and how you really transformed the community of physicians around this viewpoint, and then maybe give these guys some framework of where you think we will be coming out of COVID, and then we'll jump into it.
Okay, so COVID, this is new to everyone, and I think as Dr. Snyder pointed out, that there was a massive pandemic in 19. There have been massive outbreaks across the world over the years, but for the people practicing medicine today, for the health systems that are familiar to all of us, this was something for which we were essentially unprepared. That we are very good in operating in columns. That if you want to go and get world-class heart care or world-class orthopedic care, I can give you a center that does that. But all of a sudden, we were faced with a problem that was bigger than any of us. That no single department could handle it. No single hospital could handle it. And really, for the first time, we were forced to turn to one another, and quite frankly, forced to turn to the entire community and say, how are we going to solve this problem together? Dr. Snyder developed a strategic document which really helped shape our vision, helped us call to task on what our priorities, how are we best going to serve the patients and serve the community, how we're going to work as a partnership. And frankly, it's a commitment that we have all made, that when we practice physical distancing, and I'm absolutely in Dr. Snyder's school, I don't like the term social distancing for the connotations and frankly the implications it has. But when we practice physical distancing, when we wear our face masks, we are actually participating in this community response. That if you we're talking about doing research and studies, the fine people in Texas and Florida are participating in a study, and they just don't know it. They are showing what happens when a community stops engaging in these very fundamental activities. And what you see, and it's sort of what our model suggested, is the number of cases increases, the hospitals start to get overfilled, and patients can't get care, not just the care they need for COVID, but the care they need for Dr. Snyder strokes or for heart attacks. And so when we'd like to, every person's an individual, and we are very used to treating the patient in front of me. But this was a unique experience in that we were challenged with treating the entire community. We had to look at the health of the community, and if we didn't look big scope, we weren't going to be able to treat the patients on the small scope. Right now at this moment, there is someone sitting in the ICU at Buffalo General. The reason they are able to sit there and get world-class care is because the hospital did what it needed to do, the emergency department needed what to do, the entire county needed what to do, so that we had people staying healthy, so there was room within the system. And that's frankly a tribute to all of us, and something we need to be proud of. The reason hopefully we won't have 1918 numbers is not because necessarily we are any smarter than our colleagues were a century ago, but because we really stood up, got a sense of this as a community, and acted together.
Once we work our way through some of this, I'll have you comment on telehealth and how the healthcare system can integrate better or care for patients better. So chime in as we go, but I think we'll start with some of the numbers and give some better context for everybody. Are you okay with that, Tom?
Beautiful.
So this was from 2 days ago. I love the Johns Hopkins website. If you guys have any interest or haven't seen it, it's a great running total globally of where we are with cases. And so globally, we're almost at 13 million total cases with about 600,000 deaths. We know that we're only testing the sickest of the sick around the whole world, okay? But just taking the raw numbers that are there, we've got a 4.4% mortality. We expect many more people because there's so many people with this that are mild or asymptomatic. Ballpark, about 80% of people wouldn't need to come into the hospital if they've had it. Maybe 20%, maybe 15% actually require hospitalization. Maybe 5% require ICU care. We think the mortality rate should be closer to 1% or even 0.5%, but only time will tell, okay? Again, putting these things together into context, we've got about 3.3 million people infected in the US alone. Any of the panelists have any idea what the population of the US is? It's about 350 million-ish. So we're at 1%. Have you guys heard the term herd immunity? Herd immunity means how many people need to get infected or have had the virus successfully and hopefully have antibodies so that if the virus is trying to jump from person to person, they jump to somebody where the virus can't replicate significantly and spread. We think we need to be at about 60, 70% of antibody producing people to be at herd immunity and stop the spread of this. We're at 1% right now. There's no way we're going to wait or get to herd immunity. Our goal is get a vaccine so that our bodies produce antibodies and get us to herd immunity that way. That is our current role and goal. Again, let me put some of these numbers into perspective. If there's anything I think that's transformed coming in and out of this, it's a reappreciation of what it means when someone's sick. How many people remember that you used to get a cold and tell yourself, I got to tough this out. I got a really important day. Let me go into school or work. Or how many parents might say, I've either got to send my kids, I don't have daycare, or they have to say, if I don't go into work, I'm not going to get a paycheck. That entire philosophy must change moving forward. We cannot allow individuals that are ill to go out into the workplace and then in some way be unprotected and spread this. That concept has to change. These might be slightly high numbers, but they're numbers that are out there. In the post-vaccination influenza world, guess how many people in the world get influenza a year? 1 billion. There's 7 to 8 billion on the planet. That's how many people get influenza every year. And globally, it could be high. 500,000 or so die every year from the flu. And we often, this virus is not the flu. It is much more deadly. It is very different. But how many times did we just say, oh, it's just the flu, it's nothing? This virus has to transform how we think of infectious disease in general. So 3.3 million people in the US have confirmed positive with 135,000 deaths. That's about 4.1%. New York alone, New York has about 400,000 confirmed cases, 220,000 in the city. Erie County has 8,000 of those positive cases. The mortality rate much higher than global and overall. Erie County itself, 8,000 confirmed cases with 650 deaths with an 8.4% mortality rate. When we look at the country in general, these are positive cases per day. And so early on, April-ish, when New York was peaking, we were having about 30,000 cases a day, okay? Remember, this is a cumulative list of cases across the whole country. What has us concerned about this 60,000 cases a day is that more and more and more states are having elevated increase in case numbers, okay? And what we worry about is the healthcare systems at some point getting overrun. When we look at mortality rate, if you can keep the flood of sick people coming into the hospital at a lower rate, you can use the resources of the hospital to care for them. Where we start to get worried, up here, UK, Italy, Spain. How many remember the stories from Italy of we have nowhere to put people? We can't fill anybody into the hospital. The 10, 12% mortality rates are because you allow the floodgates or the wave or the tsunami to hit the healthcare system and get it beyond its resources. The US, by the way, is the most positive cases globally, and that's the 4.4% right there, all the way there. And then Brazil's not too far right there behind it. When we look at New York City and why we're having so much conversation around Florida and others, is New York at its peak had about 11,000 cases a day. And this was enough just about to overwhelm that city in the area of what we could do. We had to bring in the fleet. We had need to open up beds elsewhere. And that really put a strain, and that's what contributed to a higher mortality rate. Florida is now crossing that barrier. And we know that once the case numbers kick in, the illness really kicks in 5 to 7 days later. And so as we see surges in cases, we see it start admissions into hospitals and ICUs pick up, and that's when we run into trouble. These are all the available beds that were available in the New York area. These were near where we were. Once you get above available beds, these are the limit of ICUs. This is where we were. Here we're projecting Florida. Thank God it looks like it'll stay below all ICU beds, but it's going to go above ICU beds. All the measures that Dr. Tom Hughes brought up, the ones that we learned about from the Spanish flu, are non-pharmaceutical. They're stay away from each other, wear masks when you need to be close to one another, and limit travel. They're the non-pharmaceutical measures that help stop the spread of this virus. This is Erie County itself. We had about 300 inpatients at one point, and thank God our numbers are coming down. And this is to Tom Hughes's credit and the messaging that he's put out through the community and others. And this one main principle: masking is the most critical factor that we can put into play. It's what's protected the healthcare system. I see COVID patients almost every day. I have not brought home yet, thank God, an infection either to myself or to my family, because I am masked every time I see those patients, and they are masked every time as well. All right, our prevalence in the hospital is half of the community because of this factor alone. Look what happens if we stop masking. If we go to 25% of the community masks, Erie County blows up again. Atul Gawande said one really interesting statement. If 60% of the people wore masks 60% of the time, we'd stop the spread of this virus. Pretty powerful. Tom, any comment?
No, I think you're spot on. The hospital is actually a fascinating model. That if you look at even cases of COVID among healthcare workers, the people who are treating COVID are less likely to be infected with COVID than people who are just conducting their normal life. And the reason is they take this stuff seriously. All you need to do is see how bad this can be, and you find your religion around it. You wear your mask, you wash your hands, you do all of these things. And quite frankly, I think speaking for everyone in healthcare, we were afraid for our families that we did not want to be the ones who brought it home to our children, to our parents. And so I think when you get that this is something other than a distraction in your life, and that this is something that we all have a societal responsibility to, then these numbers become much more real. And you look at these models, and these are analytic models. They're hypotheses, but we see the models playing out. You look at some of the other states that don't have the restrictions, and they're getting themselves into real trouble. And the frustration for me is they're choosing to get themselves into trouble, which then goes back to my standard or my earlier comment that's why science matters. That we have to understand what science is saying, but we have to believe what it says.
For each of you on the call, one thing that's really important is learning on your own and reading it on your own, because what you'll see is people can pull snippets of a comment out of a paper uncontextualized. And if you haven't read the paper, you don't understand that there's not the right logic to what they're saying. So for example, we know clearly, and I'm going to get into this, Tom and I'll get into this in the lecture, that the higher comorbidity elderly people are where the high mortality rates are. Really, if you're healthy and young, it can affect you. The probability is very low. This comes back to some of those stochastics we wanted to talk about, that people are terrible at probabilities in general. But the probability is low that you will have a problem as a child, as a young kid, okay? 20 years, 30 years, although they'll happen, you're going to hear the story, the vast majority will not be affected by it. How they will affect the community is they live in a multi-generational home and bring it home to their grandparent. They then aren't protected in a mask and spread it to someone else. The messaging that's been going out around schools have been open, pediatrics are fine, they're not seeing spread. If you read the pediatrics paper that was done in, those are only in low prevalence areas. All they're saying is that kids don't seem to spread it wildfire in low prevalence communities if safety measures are in place. If schools are open and high prevalence, the paper says kids spread it just like adults do. So we have to be careful about messaging. Yes, you have more of a robust immune response with less cofactors that could push you over to have a severe component or complication from this. It could potentially happen, but realize your age group, what's critical, we can't have you as the carriers. That's really the approach to the people on this call. Go ahead, Sarah.
Oh, we have a question kind of about like the herd immunity that you were talking about earlier. There's just so much kind of like mixed opinions on it from like different news, media outlets, things like that. Could you offer a little more clarification on that? Like, is it a good thing? Is it a bad thing?
So Sweden kind of was doing an experiment. They said, forget it. Let's let this virus run rampant and let's let everybody get infected. We know that about 80% of the people or so should have mild or no symptoms, but it should spread. My prevalence in my community should pick up. And then at some point, the virus won't have enough people to infect. Well, they're not even close to getting there yet in terms of herd immunity, okay? That's why I come back to, we only have about we're doing the most testing of anywhere in the global country, and we're only at about 1%. If the implication of this disease wasn't so significant, death to a loved one, right? At a rate of maybe 1 in 20 or higher if it's older populations. Who feels that's safe enough to play Russian roulette and let this run rampant? The implication's too severe. We are buying ourselves time so that we can get to herd immunity almost immediately by vaccination. Once we've proven safe vaccination, that's what herd immunity then is. You build antibodies to the virus with a different process than becoming infected by it, all right? And so, you can't say I don't believe in herd immunity, but yet I understand how vaccination works. They form the same principle. Your idea is not give the virus something to catch on to, no dry brush for the fire to keep burning at, right? That's where we need to get to. The question becomes, do you slow things down and slow it down so that there's a trickle into the hospitals and wait for a vaccine? Or do you just let it run rampant and let it happen naturally? The answer to that question is going to be, we're going to go from 130,000 dead to 400,000 or 500,000 dead. And then maybe we'll hit the herd immunity. Do you accept that level of death for potentially you or your loved ones? That's the dilemma. Tom, anything to add?
No, I think you're spot on. And we've seen this for generations. There are a lot of ways to get where we want to go, but there's a price to pay. You know, as a purely editorial thing, I think physical distancing, masking is a very low price to pay to save literally hundreds of thousands of lives. And yes, those lives buy us older. It's your grandparents who are going to die, but younger generations are not immune. We see deaths essentially in every age group. I don't know if anyone saw it, but there was a news report just the other day of the first identified case of a baby getting coronavirus in womb. So this is a very potent virus, and viruses are likely the oldest things in existence. The reason they continue to exist is they're not stupid. They know how to adapt, and if we give them the room to adapt, they're going to move around us. So this is our opportunity to do it one way or another. Because the next question is, when we do have the vaccine, we need the social willingness to actually get the vaccine. It's if you look at the early reports, it's likely we might have a vaccine end of 20, early 2021, which in historic terms is unimaginable. And the idea that that we can then use that tool to reopen and return to normal life is inspiring. But as a society, we need to say that this is where we're going and this is what we want to do.
On that
Sorry.
note, oh, sorry.
No, go ahead.
We had a question about like long-term effects on the younger patients. You guys have been mentioning, Dr. Hughes, you mentioned like a child in womb is now getting coronavirus. Is there like long-term effects on the younger patients that might have COVID-19?
So great. I'll come to some of these, and it becomes a question of the severity of the illness. The most common pathway and where your immune response kills it is in the lung. The lungs are two giant bags of sponges, but often that lung could be scarred significantly. And so you may not notice it early because you've got so much other healthy lung, but you will have damaged lungs, significantly damaged lungs as the body tries to kill this virus. You can have long-term neurologic consequences because the virus climbs up your olfactory tract into your brain. All the people that say I couldn't smell for a couple weeks, that virus has entered their brain, and there are long-term or could be long-term consequences for those. Just because you're young doesn't mean you're immune to them. You think about it as how sick did you get? The most severely ill from the virus have the longest term consequence that could be there from it. I know there's only a few minutes left, but I want to set us up for next time, a couple things. We in UB Neurosurgery have been very fortunate in Dr. Siddiqui and my partners' interconnectedness with this world globally. And very early on, we had a webinar with China at the three main centers that were dealing with this virus: Wuhan, Beijing, and Chieten. We had the physicians that were dealing with it in the crux talking to us in America about what they were facing and what's going on. And to Tom's point, they were the ones bringing it home and forming the clusters and forming the infections. The main message they were sending was protect the healthcare system and protect the healthcare worker. Because if you lose that battle, you will start to spread this virus like crazy. And we learned this from them. And we talk about treatment strategies around proning individuals, et cetera, et cetera. I also have one of my co-fellows, David Langer. I don't know if any of you seen that Netflix show. I have yet to see it yet, but this is him for Northwell. He was one of my co-fellows. He's one of the leads on that Netflix series, but he is an incredible human being. And he not only worked from an ICU perspective in Lenox Hill in the heart of COVID, where they had over 400 patients a day, he also went to the Jovitz Center and volunteered his time to see all the patients out there in the cohort. So he lived it. And he was giving us a webinar in the thick of it. And what he was sharing with me is, Ken, you can't believe what it feels like to be in New York right now. He said, there's no one on the streets. I come out of this day of death and I walk home in a silent New York City. He said, it just is the eeriest feeling. I can't describe it in words. And he did this day after day for a period of months and still does. But we in Buffalo, we're having exquisite insight into the reality of the treatment of this virus across the whole globe because of technology like this that really opened up our eyes to help us prepare for when the wave came here. I think that that'll be a good place to start, because what I want to start talking about into next week is what was so weird and strange about what people were seeing in stroke. I then want to talk about how the virus works, what treatment modalities we have from it, and then we'll wrap up with kind of more intricate into lessons learned. Does that sound good?
Perfect.
All right, great. Tom, I hope you can join us tomorrow.
Yeah, looking forward to it. Thank you for everything.
Do we have time for like one last question?
Of course.
Okay, we have a lot of questions about schools reopening. Do you have any thoughts about should a school reopen, should they not, things of that nature?
Based on that pediatrics paper, I think the idea of using local prevalence makes a lot of sense. What do I mean by that? And now the difficulty becomes the age of the kids. Let's take our age group on the phone right now. If we mask, first of all, what are the safest things? Outside. I wish we could do classes outside, okay? If we have to get in a confined corridor, realize that circulation of air is critically important. Why? If I'm outside and I cough a virus, it goes into the atmosphere in the community around and blows around. There's much less chance from an entropy standpoint for it to be hovering like a cloud, like there can be inside of a room. So ventilation within a room and all those things are really important. Keep the windows open as much as you can if you're in school, okay? Space out the seats 6 feet if you can. There's no magic number to the 6 feet. That came up because of measles outbreak in a school where the kids' seats were 3 feet apart, and the CDC just decided to double the number. The only science done on the spread has been in the military, where they put dishes on the ground and watch people cough and see if bugs are picked up. And depending on the wind, it can go out to 9 feet or 12 feet, okay? So the best videos are the fluorescence videos of cough particles, masked and unmasked, of people just talking or sneezing or coughing. Masking makes a radical difference on what we spread. And know that this virus goes from one person to another by hooking onto a droplet and getting onto somebody else and then touching their mouth or their eyes. That's it. If you can break that transmission, you break the spread of the virus. Schools should reopen in low prevalence as long as we social distance, wash our hands and disinfect and wear masks. Who needs to be protected? The 65 and older teacher with comorbidities. That's the people we need to be worried about. So I like the plan, like most schools. I've been involved in the UB's planning reopening. And then the other is this periodic testing of prevalence. We need to come up with a good plan, but be able to change the plan if something changes. If all of a sudden the area blows up to 30, 40%, it may not be smart to keep schools going. Tom,
Actually, Dr.
Go ahead, Tom.
Can I jump on that? Because I actually think you raise an excellent point. First of all, stepping back, I was a standby observer in those conferences that Dr. Snyder was describing. That is medicine at its best. The fact that we could sit there, using the same technology we have right here, learning from people on the other side of the world how to treat diseases in real time, like that's science fiction stuff. The fact that we can have this conference today is just incredible, and it's going to allow us to learn in ways that we never imagined learning. So I think when we talk about the issue of school, there is one, and it goes to this concept of social responsibility. Yes, there's one part of the role of school, which is education, and I think that things like Zoom technology are transformative. And I'll be honest, I think that some of the schools did better than others in the spring, but they've had a summer to prepare. I think it's going to be a better experience. But as a society, we also have to be aware of the fact that schools have roles beyond education, that particularly when you look at underserved populations, they are sources of nutrition, medical care, behavioral health. And so as we look to adapt our society to help confront this virus, I think we have to parse out what we're doing and find ways of replicating things in proxy. That yes, we have different ways of providing education, but how do we meet these other critical needs of our society? Because if we look to take care of better people, quite frankly, at the end of this conversation, and this is a space around transforming healthcare, we might do a better job of taking care of people than we did before the pandemic. It's an opportunity for us to challenge ourselves.
Thanks, Tom.
Thank you all.
Thank you, Dr. Snyder and Dr. Hughes, for coming on this call today and for giving us your insight onto COVID and also with strokes as well. Just a friendly reminder to please complete that SurveyMonkey. The link will appear at the end of this webinar call. But thank you so much for joining us today.
See you all tomorrow.
Have a nice night.
Thank you.